And so with that, I would like to introduce and welcome our last keynote speaker of this year's symposium, Dr. Debarchana Ghosh. So Dr. Debs Ghosh is an associate professor of geography at UConn. As a health geographer, Dr. Ghosh's research and teaching are primarily focused on the relationship between place and health, where place is a multidimensional unit connecting people, such as vulnerable populations, things, such as facilitators and barriers, and the environment. She informally describes herself as someone who is driven to understand how health is affected by anything outside of pills, needles, and scalpels. Therefore, she continuously strives to study how behavioral and contextual factors interact to affect health at several geographic scales. The ultimate goal is to conduct spatial behavioral interventions where research findings are translated into practice. Dr. Ghosh visualizes this as a way to give back to the vulnerable populations and communities that have historically experienced societal level exclusion and marginalization. Dr. Ghosh incorporates research into pedagogy by teaching undergraduate courses on health geography, graduate courses on spatial analysis of social issues, and a hands-on course on GIS for health and environment. In her 10 years at UConn, Dr. Ghosh has advised, both as a primary major and as a member of the advisory committee, for 4 students in the geography major, 1 student in the GIS major, 15 plus students in the individualized major program, 3 MA students, and 11 PhD students. And so with that, I would like to welcome Dr. Ghosh. I took a class with Dr. Ghosh last year, and she's the inspiration behind the title and theme of this year's symposium. So we're very grateful to have her here as our UConn keynote this year.
Thank you. Can you hear and see me? Okay. Okay. Yeah, thanks for inviting me for this year's symposium. And it's my honor to be here and excited to close this year's symposium with my lecture on health geography as a function of people, places, and health, which goes very well with the topic or the focus of this year's symposium. So what I'm going to do now is I'm going to share my screen, and we can briefly start with knowing what health geography is, and then talk about, then I will share some knowledge and examples from my research. So let me share my screen. Can you see my screen?
Yes, we're able to see it.
Okay, great. Let me move this here. As I said, I'm excited to close this year's symposium with a very relevant topic here: health geography as a function of people, place, and health. So as some of you may know, some may not, in the audience, health geography could be a very new thing to you. Apparently, geography and health are increasingly linked. For example, the people that we come across along our life course, from our birth till death, friends, family members, co-workers that we hang out with, have impact on our health decisions, health-seeking behavior, including healthy behavior, risky behavior, and so on. Similarly, the places that we live, we work, we hang out, also along the life course of an individual, we interact with different kinds of places. The things that are in the places, for example, the air we breathe, the pollution or the clear air, the things that we eat, the bacteria and the viruses that we are exposed to, as well as some of the health resources that are available in the places that we have spent time during our lifetime or our life course, also has a lot of bearing and significance on our health decisions, health status, and the health-seeking behavior, basically. So with that comes to the definition of health geography, which is a subdiscipline of geography, or you can say subdiscipline of human geography, which uses geographic concepts, theories, methods, and approaches to understand the complex interaction between people and place that produces disease, health status, as well as well-being. This subdiscipline of geography has a strong overlap and has been developing simultaneously with two other very predominant and fields in health studies, epidemiology and public health. More recently, health geography is also playing an important role in public health policy, where beyond the social determinants of health, which is mainly the focus for epidemiologists or public health, the structural determinants of health, which are found in these places, the policies in the places, the people involved or people who live in these places surrounding them. So those really comes into the structural determinants of health and how investigations or research or our interactions with those has an effect on the public health policy is something that is being done very recently in health geography, and that really intrigues me and it makes my passion for health geography much more when it is linked to policies and things that can have more actions. This is a table which kind of shows few examples of health geography research, how it can be relevant to public health policy. This is not exhaustive. Things are changing and developing very quickly. But as you can see from the column on the left under the research area, you see studies which focus on infrastructure, land use planning that can lead to studies related to how easy access to our health resources, or easily we can access healthy foods or not healthy foods. Then you have the disease surveillance, modeling, and mapping. And for the last 2 years or so, we have seen so much of work done from the spatial context, from the geographic concept, from the community concept in terms of COVID-19. We have seen numerous models and maps and dashboards and web mapping, interactive mapping. So all, I don't have to emphasize on that more, that how that is important. Then you have a section or a group on disease etiology and determinants of health. This kind of studies overlaps with epi a lot, epidemiology a lot. And then you have other groups like the health service use, inequalities in health outcomes. This is one area that in the last two years that I've been working passionately in health equity and inequalities, health disparities among vulnerable populations. So this is just a selected list, and it is evolving very fast, this field. So coming back to my title here, and I want to focus on this word function. Some of us who has a math subject or stat subject, you probably have seen this notation quite often in equations. So it's a function. So how do I see this function as? So I see this function equating health geography with these three things on the right, which are people, place, and health outcomes, diseases, and whatnot, as they are interconnected, they are overlapping, they are talking to each other. One is impacting another. So it is really that tight way of bringing all these three facets of health geography together in a functional way. And this part is where most of my research and teaching are. How we can bring these three things coming together. What does it mean when we talk about their interrelationships, their connections, and knowing that they are interconnected? What are some of the policies, interventions that can be implemented, which is meaningful and actually can work, because they're all interconnected. So we cannot have things in isolation. It has to incorporate these three things together to really understand health in a holistic way. So this is where my research is, and also most of the health geography work also is. And in terms of teaching, when I bring research into pedagogy, I follow the similar thing for my courses. And the one that is very relevant, as Amisha talked about in the introduction, that I teach health geography, connecting people, place, and health, primarily in the fall of every year, an academic year. But this year, I'm also doing a compressed version of that in the summer. So this is the first time I'm offering this course in this summer. And then I've always done once a year, mostly in the fall. So with that, let's see how I am going to kind of explain this interconnectivity with some examples, and very briefly, some examples from my research. So here is an event that happened in less than 2 days, basically, August 15th and 16th in 2018. More than 100 people overdosed on synthetic marijuana, the K2, in New Haven, Connecticut. So very close to our home, our campus. So it's a very unfortunate event. And I want to use this event to see how place, people, and health are connected. And we need to understand each of these things and how complex it is to bring them together, and kind of understand why it happened, how can it be prevented in the future. So let's get into this event and see what's happening here. So the place here is the New Haven Commons, or Green, a large park in the city's downtown. Many of you probably have visited this area, or probably walked from one side of the park to another. Here is a map which kind of shows the exact location of the New Haven Green here. Then some of the very well popular streets around the Yale campus, and so on and so forth. So you can see the geographic location of this place. Now, this is an aerial view of that, which shows more zoomed in features or characteristics of the place, and things like that. But here, it happened that in a less than span of 2 days, almost more than 100 people overdosed, and people were unfortunately passing out. They were almost somewhere close to death in that small area. And as you can see, there are some governmental buildings, administrative buildings around it. I believe somewhere here is the courthouse as well. And 1 block away, you have the famous Yale University with the maximum health facilities you can think of, and a bunch of very well-known researchers are also there trying to prevent this kind of things to happen. So close to where people knows why it happens, the background of it, but it still happened. So it really intrigued me that, oh wow, it's 100 people. So it kind of stuck to me, this story, and I wanted to expand on it and see how health geography approaches and frameworks can be understood, or can be placed over this story, and we can really make sense of this. So going next to the people, we can see who were involved. Is it just unfortunate people who were there that day, who got attracted to trying out something new, or they were drug using networks who usually hang out in this area, or the drug dealers? How did they come all together here? Did they have a network? Did they have a drug using network, or just a bad friend? So all these questions can elucidate a lot of information. Another thing that intrigued me is, did the commons, being the place, attract the users, which are the people, or the users decided to use at the commons? So why exactly this place, which is so famous there? It's got an historic background, surrounded by administrative buildings, yet this event took place. Then what happened here is the health. It's the health, that is, the people overdosed by using K2. And if you don't know what K2, you're not missing out, but K2 are human-made chemicals that can be either sprayed on dry plants and smoked or sold as liquids to be inhaled in e-cigarettes or other devices, much more potent and dangerous than any other illicit drugs. And it has got numerous street names. And very recently, there's some incident also happened with students from the Wesleyan University, I believe. They were mistakenly, they overdosed and thinking something else. And there was also a recent bust in some place in Connecticut, where they acquired a whole bunch of a significant proportion of illicit drugs. So, and with the with the pandemic in the last two years and still carrying on, opioid and drug addiction has really been a problem. We are seeing a big rise in these cases. So, bringing all these three together, I want to focus on this overlapping area, which is where I'm more intrigued and where the core of the health geography concepts and approaches are, which is at the interplay or the connections between this health, people, and place. So what was the environment in the New Haven Green? How are the place and the people connected? Are there regular hangouts, work activities going on there, where the people were just passing by that day and wanted to stop at the park? And what other things or activities usually happen here, which could either facilitate this unfortunate event, or we could also come up with other activities around that area to stop such future unfortunate events to happen. So the idea is that to understand this kinds of health situations or health outcomes or health outbreaks, it could be COVID-19, the infectious, or just overdose or other non-communicable diseases, that it would be futile to see it singularly. You have to see in holistic way, including the people, including the structure, including the context, and including the place around it. Otherwise, we will not be able to understand the underlying causes, and therefore we won't be able to prevent it in the future. So my research, overall, kind of lies in this area here, is this overlap. And one of my research is on understanding the transmission of HIV and their treatment barriers among opioid users. So they have double health issues, that they have opioid disorder, misuse disorder, as well as HIV. And I bring in other facets, like where do they work in their daily life? What are their daily life activities? What are the people they hang out with? How did their social networks look? Is it do they have supportive people, or they are hanging out more with their drug using friends? It will have different implications. As I said, the health part is the drug overdoses. Now, each of this can be studied under health geography in its different approaches and methods. And also we could do in health geography, as well as by incorporating interdisciplinary techniques from epidemiology and public health, how to measure their connectivity or interplay, that this part here. So I did this study in Washington, D.C., and the data collection happened for more than 2 years, starting from 2013 to kind of around 2016. Then we started doing our data analysis. So around that time, the situation in Washington, D.C. has always been critical when it comes to HIV and opioid and drug use behaviors. But around that time, it was still high. But in 2019-20, we are seeing some good effects, that the numbers are going down. Although the prevalence could be going down, as well as the incidence, the newly diagnosed ones. But there's some other issues that are still very persistent in this side of the country, which is one being the new diagnosis. It's more among male. Then you have ethnicity disparities, an issue here where it is seen more among the Black population, and the new cases are in this area. So you can see 35.3% is that very young cohort, which is not a good sign. So it's one of the risk factors, all three together. But then overall numbers are improving in terms of Washington, D.C. area. And as I said, the disparity of the HIV outcomes are not equal. It is unequal and among different races. As you can see, the rate of Black males living with an HIV diagnosis is 3 times than of white females. And this number is 35 times more among Black females than the white females. Then here are the numbers between the Hispanic and the white counterparts. So the health disparity is still a concern. So I'm not going to go through this complex study design. All I want you to know that we have around 150 study population, which we interviewed. We had counseling, several things were going on with them. And they were all HIV positive and had a diagnosed opioid disorder level. And several people were involved in this study. As you can see, some colleagues focused on this one. I focused on the secondary objective, where I looked into that whole place effect, the network effect on their HIV treatment, as well as their opioid drug outcomes. So this was our sample. I focused on the place, the people, the way I started this to talk about how they're interconnected. And I looked at effect of that interconnection on HIV treatment and opioid outcomes. So let's start with the HIV. How did I do this using health geography approaches and concepts? So I had their blood draw reports where we collected their blood, and we did the test of HIV, and we knew how much was the infection in their blood, and they are called the viral load. So I mapped them here, and the darker the shade is where the people who were sampled from and had higher infection level, HIV infection level in their blood. And as you can see, the lighter areas, lighter yellow colors are where the infection was on the lower side. And as you know, there was no cure for HIV. So the objective of the treatment is to reduce their viral load as much as possible in their bloodstream so that it cannot be transmitted. So that's what is called if it is that low, then their status is called undetectable, which means it's so low, the machines or the apparatus that detects the virus in the blood are unable to do that. So it's undetectable. So everything outside this black line, we have undetectable, which means the people who were in the study had very, very low infection. But everybody around in this area with high warmer colors and this red areas have higher HIV in their body. Now, if you can see on the left here, the sample, as I said, divided into undetectable and detectable. Quickly, I will show you some background of the people here. They were all about 50, which means this also has an interesting manifestation here, because they're about 50. They have gone through this double stigma in their life course. One being high on opioids, as well as injecting drug users, and then you have the HIV. So they were bearing this double stigma of health outcome in their life for very long years. interestingly, also, most of them were not married or were not in a relationship. And I will explain that why I wanted you to remember this, which means their support system is small. It's not saying having family is always is always has a positive thing. Some families cannot be doesn't provide a positive support, but you can say that there are less people in their life who can come who can be of support. They were almost in poverty, unemployed, and along with that, along with the HIV issue, they also have craving for opioids. This number means that they are craving for opioid is measured on a scale from 0 to 10, and the higher craving group is when they have some kind of value from 7 to 10. As you can see, most of them had that issue. Coming to the social network, this is a approach that are used in sociology, in business, in computer science, but it can be also used in social science and health research. And this could be a whole class, whole course by itself. So I'm not going to go into the whole the theories and measurements of social networks, but all I want to say here is that following that approach, I had a social network questionnaire, which allowed me to ask these questions that you see on the slide here. And I had a list of people in their life who were important, who were supportive. So think and identify all people that are important to you, people that accept you as you are. There's no judgment there. And then think and identify people who are most willing to help you. So I asked this question, rather the RA group asked this question, and we enumerated a name and a number of people that could be supportive in their life. And on the other side of the spectrum, I also had two questions. Think of people you know 30 days ago when we were doing this survey who used drugs or who were engaged in some kind of a criminal activity. And that together made the risk network. So this was the support network, the questions, and these were the questions for the risk network. So with that data, what I did was I kind of drew networks diagrams for each of my study participants. And this is kind of an involved here. So I have this legend. You can see this color, this person in the center is our study participant, and these all numbers are their study IDs. The lines is how many times they interact with or they meet. The thicker they are, the interaction or meeting is more. And then you have shapes and colors. Shapes tell you circle, whether they were family members, square, some kind of friend or acquaintances. And red is where you have the risky behavior, which means they were either conducting risky sexual behaviors, which might be risky for transmission of HIV, drinking, criminal activity, all those together, and then none of that. And sometimes we did have missing data from our survey. That's the color when we have gray. So that's the way, try to kind of see these diagrams here. This is one person which has got quite a few of people they have mentioned in the survey. And from those set of questions which were that generated the support network. Mix of people who does risky and non-risky behaviors, as well as mix of people from family and friends. You can see the circles or the nodes in circles and squares. This is another person. There were only 5 people, which could be or could be bad or good. But looking at the risk network, you can also see that they are smaller, and which is kind of expected. You don't want your risk network to be bigger than your support network, although it can happen, but typically that was not the case. I drew this for all of them, and this is just to show you how it might look. And you can see that in general, the network size, irrespective of supporter network, supporter risk, was from 3 to 4. The bigger was the support network. And in the support networks, the people from the family had no risk behaviors, whereas people from the friendship or friends had more risky behavior. So these were the general. There were exceptions, but these were the general trend that we saw in the people or the social networks of the study participants. So how can I map them? Because I want to see the area where these people are interacting with each other. And that's why I'm going to bring these two overlapping circles of place and people together. So I had the location of all these people, and I kind of drew them on on our map, and did some, and this you cannot interpret a lot from here. It's just I have put all the networks on the DC area just to show how it might look. But technically, what is more useful is to draw their the space out. So how much, how much you have to go, the person has to go to meet with the risky people in their life or the support people in their life. So that was the main objective. I wanted to see whether if somebody that I need right away is nearby or far away. You can say that in this highly communicative life, sometimes I could call my best friend who is in Texas, right, or in Ohio. So I can call them. Yes, you can. At least for this research, we focused on the people around. And it is clearly possible that some of our supportive people may not be living because we move around, we move for jobs, we move for a school. So it's possible. But think it like this way: the people that we meet on a regular basis, uh, in my opinion, would have more weighted influence on me than people who are further away, who could be very good friend, but still far away. I don't have easy access. So that was my assumption, and I wanted to see that how that played out for this particular group. And again, this group, as you said, as I said in the beginning, is an elderly population. Well, 50 is not that elderly, but still they are not that savvy with their phone and their virtual networks and things like that. So they tend to be more in local or in situ. So I wanted to see exactly what I said here. How far are the people who are having some risky behavior or not having risky behavior? For this sample in DC, it looks like all of them kind of lived close to each other, or they were hanging out with their regular activities of work, leisure, grocery stores, and whatnot, very, very close to each other. So, and that just shows that from this graph here, the distance on the x-axis and the number of people, you can see a big, tall bar histogram here. So is the distribution. What the colors are telling you is the people who are in the red are the risk behavior people, and the blue are non-risk. Looks like all of them lived close by to each other, but the people in their networks who were having more than one risky behaviors in terms of HIV and drug use were living closer than the others. So that's the take home from the summary point from this slide. Now we talked about the health here, the networks. Let's see how am I visualizing or how am I measuring the space around that. So for that, I had another questionnaire, which kind of, it's called a free listing and recall methods, where I asked each of the participants list locations of regular weekly activities occurred within the 14 days before the survey. The 4 sets of questions looked at their work-related travel, their leisure, social, and cultural things, as well as healthcare, because this sample was suffering from several health issues, and they had places to go in terms of health-seeking behavior. And on this column, I'm not going to go into the details of it. It is beyond the scope for one webinar. Is all the methods that are used to measure their activities. So here is again that one participant where the home is here, and these are the areas where they did activities related to their social and cultural life. Then they went to these two hospitals. I think this is the Howard University Hospital here. They had counselings there, they went there. And I kind of drew again a kind of a place around it. So this is, remember, people can go somewhere farther away, but this is the regular lifestyle of a person with opioid disorder as well as HIV, who is older and living in the the southern part of Washington, the District of Columbia, below the river, below the Potomac River. So I brought all the people's activity spaces together, and we're saying, as you can see, this is not a very big area. So almost they were in small areas. Some of them did go far away, and which is possible that they were suffering this two stigmatized health behavior, HIV as well as health drug use. So sometimes they want to meet friends who doesn't know their past, or they want to go to a healthcare where you don't have to meet with your known people there. So you want to keep your anonymity, and therefore you're going further away to do your daily activities. That also came out during our qualitative work, which is focus of another faculty member, but that did come up, and that kind of explains some of these activities going beyond DC area, and this would be the Maryland area side. So bringing all these three things together, you have the everyday life, the activity spaces, the people that we interact with, and then you have HIV. Let's see this for a participant who had a very high viral load, and when we do viral load analysis, we usually take a log of that. So that's why you're seeing log of the viral load. CD4 count, which is also a measure, health indicator of HIV. You have 250 cells per micromillimeter of blood. Then you have the craving cell. This is the highest. So this person had very high craving scale in terms of their opioid disorder. This was a transgender individual, 34 years old, Black, no employment at that current time, and had few criminal justice issues or experiences in their life. So this is the person's approximate home here. And you can see underlying is that health, the HIV surface that I created. And as you can see, it is in that high air. If I go back to this is this area here. So it's a darker color. And you can see the activities I've color coded. Healthcare is again in that neighborhood. So hanging out in that high viral load area. Then buying alcohol, drinking alcohol, doing drugs are somewhere here, and here, all the black dots here. So you can see, and this is that activity space. The maximum distance this person typically travels to do their hangout, social life with their friends and kins are approximately 10 miles on this side. So, and if I do a summary of the risky activities, drug-related activities happen 8 times, then alcohol 2, and then alcohol store. So there's quite a few risky behaviors going on. And in terms of their social interactions, again, it's starting from that local area, have a couple of people in the life which are friend, which are further away. So risk behavior of all of the network people, they use alcohol, drink alcohol, use drugs, criminal justice system, or HIV positive. So all of them had the red color, which means even the family member had either of these risky behavior, and the friends who lives very close and one further away also has a similar health behavior. So these things, these details are important, because if the person, which is our study participant, we put them in a counseling or in some kind of a rehab or a treatment for which you need daily going to a health center, then these things are important to consider. Where will the person go? If the person is sick, who will take that person there? Does the person have somebody in their life? Or in terms of is the person, the people in their life has a similar health issue, then the situation is much tougher, irrespective of the intervention you can think of. So this is just a zoomed in area here. You can see that this most of the daily activities happens in a close proximity and in the area where HIV transmission is higher anyway in that area. So similar kind of exploration and analysis we did for all of our 150-ish people approximately, and this is just a very broad stroke of the findings here. I don't want to spend a whole lot, keep some time for the Q&A. You can see that people above the viral load of detection, which means they have higher intensity of HIV infection in their blood, they had relatively larger area of that interaction. That I called it as a habitus. The number of risky activities were higher than the other counterpart here. Frequent daily activities was just hanging out, leisure. The minimum distance that they went for any activities in their 14 days before the survey was to get drugs or do drugs with some friends. And for the people who had whose HIV infection was controlled by counseling, by medicine, by all kinds of treatment, is their frequent daily activities was actually keeping to the health regimen, the health visits. This one was hanging out. And let's say an average, a number of people in their social networks, they have higher than the other counterpart, which had higher HIV infection. So people living with HIV have social networks that included 3 types of people, right? Kin, extended kin and friends, including alcohol and drug users. Networks with the risky behaviors were primarily friends, and network people. The word that we use in social network language or dictionary is called alters, but let's say social networks are people in our life. People in life from risk networks clustered around the home. And we saw that for this particular case study here, everything was very close to the home. So my closing highlights for this lecture here, I'm coming back to this health geography as a function of people, place, and health. This way of looking or understanding health issues is holistic perspective. It brings social, cultural, environmental, all well-being together, and it is very important to bring them together to understand complex health outcomes such as HIV or drug use, where looking at one thing at a time will not serve our purpose well. The health geography part is where the location or the place is very important. The location, or in other words, the geographic context of places and the connectedness between places and the things in the places plays a major role in shaping health and environmental risks, leading to a bunch of health issues, diseases, as well as ability to maintain the well-being if these things can be done in a positive way. Health geography, as you may have understood so far, uses interdisciplinary topics, which makes me more passionate about this kind of work because I really like interdisciplinary field. And I believe some of our societal issues currently, climate change, race, inequality, cannot be solved by one discipline or a silo work. We have to collaborate and work with others. And as we become interdisciplinary, our toolbox of approaches, theories, frameworks also increases. Some of the future directions which really intrigues me and I'm really excited is the policy implication part. Still some work needs to be done. How does all this gets into a good policy way where we can actually solve these issues? But we are seeing this recognition of structural and policy that will have over and beyond effect on individual risk factors to a health outcome. So that is in the last 3-4 years, we are seeing the drive going to that area. Another thing that is very important, and maybe for the next generation of students here, is that community engagement. As you become more holistic or inclusive, or you expand your thinking around the place, you will bring in more of the community engagement. And this people and place interaction becomes really, really important at that time. So a couple more things I want to point out. CDC has this concept of One Health. I don't know how many you know. So if I think I opened it in my browser. We wanted to show the Zoom. Anyway, let me click on this. Maybe it will take me directly. Yeah. So as you can see here, One Health is a collaborative, multi-sectoral and transdisciplinary approach working at the local, regional, and global levels. This is exactly where health geographers can play an immense role because it talks about the scale of place. Local, regional, national, and global levels, with the goal of achieving optimal health outcomes, recognizing the interconnection between people, animal, plants, and their shared environment. I do not do animal part of the health, but it is there. It is also a thing in the place, or the life in the place. So there are also a lot of work. So that brings, this is, and therefore it's called One Health. Now, on that note, I don't know how many of you are familiar with this One Health, One Community that has been, I think it's pretty new at UConn, and it has been steered by College of Agriculture, Health and Natural Resources. Oops. And there you can see there are more resources here. There are lots of podcasts here. And it's very interesting because I saw one thing here. How do physicians, let me expand this. How do physicians incorporate ideas of One Health into their work? So physicians would be the people where they would be working with scalpel and injections and whatnot, exactly the one that I don't use, but they are also connected to One Health. So how do they see themselves in this concept of One Health? Then one of my colleague, Peter Chen, has also did a podcast on GIS can be used. One of our prominent approach or method in health geography can be used here, and you're most welcome to hear his podcast. Then see how Dr. Viradi has talked about virology and vaccinology at UConn. Then I talked about how health geography can be a part of One Health. And by this time, you've already known that the interconnectedness is very important. So I have a podcast there. So look at this. It is inspired by CDC's One Health. And this is what I was also talking about, this health geography as a function, as the interconnection of people, place, and health. One Health includes animal, which is more holistic, but it's inspired by that and One Health. So with that, I am going to end my keynote lecture here. Thanks for listening to me. It's a wonderful weather outside. So I cannot see all the participants or attendees. So thanks for attending on this Saturday. So I'm going to stop sharing and let the organizers moderate the Q&A or ask any questions.
Yeah, sure. So we do have a few questions both in the chat and the Q&A, so I can read them off. The first question is the craving scale relative to the participant, and how did you standardize these results?
Yes, it is associated to the participants. So each part, it's a self-report. So we measured the opioid or drug use level output in two ways. One was the self-reported craving scale, and it is a standardized scale. So there are several questions there, and each would have a way to measure the answer. And that would, we have a standardized formula to calculate it, and the output of the calculation would be a number ranging from 0 to 10. And along with that, we also had like a biological marker, which they had the urine test, and that also showed their drug use level in their system.
So kind of going forward with that same study, when you were mapping HIV versus drug use, did you find that these regions with high HIV rates mapped onto specific communities or demographics within DC?
Yes, it did. So, and it had a strong, if I can go to the screen share again. Where is this here? So this part is borders with the wealthy part of Maryland, Chevy Chase and all that. This is the this is where University of Maryland is there. I think that, what is that area called? Yeah. So those, as you can see, there's a sharp cutoff. So it had a strong overlap with African-American population and low income, and the much stronger was below the Potomac River. So Potomac River kind of runs from here. So this is that Anacostia neighborhood where we, over the years, this area went through the epidemic of injection drug use first. Then it moved to the opioid-driven drug use behavior, and along with that also had a long history of HIV epidemic. So, and this is the area where you have also pockets of African-American population.
So, and then kind of moving on to health geography more broadly, is health geography only related to epidemiological fields of health, such as infectious disease, drug addiction, or does it also extend to diseases such as cancer, heart disease, diabetes, etc.?
No, all, because I also, my current work is actually with cancer disparities, and I'm looking into the effect of racism. So my work is on that structural policy. So I'm looking at the effect of structural racism and discrimination in the places that people have lived with cancer, on their cancer outcome and the disparity. So all of them, and not only epidemiology, but also public health and social work. So when I was talking about the policy part, the community engaged part, I have done the community engagement part, but not the policy part yet in my research. If I take my results and work on the policy side, I will probably collaborating with social work scholars, and then go out in the actual neighborhoods and the communities to implement them. So not only EPI, but public health and social work.
So I guess this is a question that I kind of had in terms of how do we make that shift to policy, right? How do we use this to inform policy or work with policymakers? Do you have any insight into that? How do we go from just having these research papers and data and then communicating it effectively with legislators so that we're able to create that policy that creates
Right.
change?
there are several complexities and actually for the policies to get implemented. But you were on the right track in saying the disseminating part. So the first step to go to that final goal of policy implementation is a better way of disseminating our research that we do sitting in the universities. That is not helping. That it helps in the first part, but we have to talk to the people that we research on. So we need to have a very good dissemination processes that involves community members. We think that we did our work very well, right? We did our maps, we did our data analysis, but we have to have a part where we disseminate in a simpler way other than peer-reviewed papers and involve the community members to give us the feedback, to ground our findings in their lived experiences in these places and the people and whatnot. So does this make sense? So once that part is where our researchers can help a lot. And after that, it is with the local activists, the local policymakers, we have to go the slow step. It's not non-trivial, but that is the part we have to go on doing it. If it is trivial, then it's not research. That's not so. But it can be done. There is a pathway, and it starts with the communication and inclusiveness.
So another question kind of goes in line with that idea of working with sort of the community. So when you interact with communities, what other professions or professionals do you most commonly interact with, and what challenges kind of exist in collecting data for studies or also just working with a diverse group of individuals?
Right. Definitely, we would be needing a training and understanding how to behave, talk, and interact with diverse population who are different from the researchers. So that is one thing. And another training that all of us should be very careful and cognizant about is our position. Like when I do community work or kind of research in the US, my position is different versus when I do things in India. So I would have more knowledge there, less knowledge there. I may or may not be felt inclusive going to a Black community here. In similar way, if I'm going to India, I have 15 years or more than almost 20 years of lifestyle living in the US. So I may have changed. So we have to be very careful and cognizant about our position as a researcher when we go on. And that is part of our training. And that is called the positionality of a researcher doing either qualitative work or quantitative, so that we don't bring our own biases. Right. So that is a challenge, but that challenge can be done with the training. Now, in terms of other challenges, that is a little hard, and but we have to keep working, is gaining the trust of the people. I just can't land up there with the iPad and start asking questions about their life. So it will not work. And one of my aha moment of this 2 years plus of pandemic is that when science was so clear about the impact or the effect of vaccine, this mistrust, that is mistrust, not necessarily with the current vaccines. It has been mistrust with the whole scientific world, how things happened in the past, which unfortunately played role in this of the mistrust in the current situation. But what we are missing here is we are blaming them or being hard on the people who are not taking the vaccine of their mistrust. But that mistrust is not for a few years, or not only for COVID. It has there for a long time. Many vulnerable communities have been used as a place where drugs were tested without. So that trust is the challenge, and we need to work on that.
So I think along with the lines of trust, I think a lot of the topics that you have presented on today and just the work that you do, there's a concept of stigma, right? HIV, AIDS status, as well as drug use. So how does, so some of these topics being stigmatized, how does that impact your research specifically, and how you were able to collect data or interact with these communities?
Um, yeah, stigma is a strong component there, and how I incorporate or the team incorporates is exactly the same. We have to be patient. We just cannot land up there with the questionnaire. They have to we have to gain the trust of the community, taking more careful of where the interviews are happening. This is several years back, so we had that face to face. So we just cannot have people asking HIV related question in the hallway of a clinic. We have to have a separate clinic there to go. And this is very important because when they talked about some of the barriers, they talk about why they are unable to maintain their HIV treatment is one of them is stigma, and the signs that they see in the health clinics, sometimes they are written very big away, go here for HIV testing. So somebody who doesn't want to reveal that will be going past that big signage and going into that room. There's no right and wrong way answer here. Some of the hospital people say, what do I do? Not have the sign there? How will I direct people? So I'm not saying there will be always an easy answer to all this, but we also have to understand from the participants or the people who are stigmatized from their point. If somebody wants to keep the health outcome anonymous or and confidential, walking past a big sign of HIV testing here and going into that is giving away, and that could prevent him or her not to do the HIV testing, would be very wrong and critical in terms of his or her treatment being started. So these things were very revealing for me, and this is one of my very initial project. Straight right off my first few years of assistant professor, I learned a lot, like beyond what my data can tell me. Yeah.
So we have, I think, three more questions and then we'll wrap up. So do you believe that geographically proximal positive social networks would attenuate the effect of the drug epidemic?
A very general question, and it will be by place and the sample wise. It's not easy to say that question. It really depends. Some of the communities are very close knit. Some of the ethnic minority are very close knit and close groups. So for them, proximity is important. And we cannot have a health intervention far away in a different neighborhoods. They will never go there. But in some other communities, perhaps that close proximity, geographic and family wise is not there. So it is, and that's why this variation is also part of health geography. We cannot have this one set of things for all.
So then if online sources such as the Google Images and Maps only give very broad representations of local areas, how can others not in the community know which places need help? Or even in conducting research, I know a lot of health data is protected, right? It's represented in census tracts or it's represented on a statewide level. So how can we really understand communities at a micro level when we don't have access to that kind of data?
Yeah, that's a challenge. The data is there, and you will not find fine-grained health outcome data all the time because it is protected by privacy and confidentiality. So to answer this question, this broad scale level maps and data and information will give you the first story, the first understanding level, and that's their purpose. They are not telling that you will go to you will understand community health from a county level map. That's not the purpose. But for that you need to work with the community people and have a different approach. So that's two different approaches. One approach leads to broader findings, one approach leads to deeper finding, and it's a different thing. One example is the Johns Hopkins dashboard of COVID-19. Everybody knows that. It's on a county basis for the whole country. That makes no sense for our state. There are 8 counties, right? So the dashboards that you will see, we have one from the Department of Geography, Connecticut Department of Health has that, Yale has one. They're all at the town level. For us, the town level is a more community. So then we will incorporate that approach, learn from what Johns Hopkins did, and we will do that in our local area.
Of course. And so then the very last question is, what do you believe is the most valuable aspect of the data and correlations produced by research like this in health geography?
So the question again?
So what do you believe is the most valuable aspect of the data and the results that are produced by research like this, both in health geography and in general? What can we take away from this if we're not exactly immersed in the field of health geography, but we're an external field or yeah, just community members that are looking into this?
Right. So first of all, data is very important. So quality data and protected data is important. And the takeaway from this health geography, if you don't want to be immersed, is be cognizant or understand that any health issue is not singular, and there are several factorial or I'm going back to the definition of One Health, that level which leads to an health outcome of a person. To really solve some of our bigger social issues, including health and health disparity and community health, we need to understand their culture, their society, their needs, their access, and all of them together, along with their individual disposition or risk factors. So to again, and if you want to take away a few things, is that my title is the function of people, health, and place, and their interplay and their connections.
I think that's a great way to wrap up. That's I think the key of both health geography, but also how we should look at global health in general, more broadly, as a function of people, place, and health. So thank you so much, Professor Ghosh, for coming and giving this lecture. It's a great way to wrap up our 5th annual Global Health Symposium. And thank you to all of our participants for joining us today. And we look forward to seeing all of you at our future events, and we hope that you will stay in touch and consider joining our organizing committee for this upcoming year. Thank you so much.
Thank you.